The treatment of metastatic urothelial bladder cancer has changed hugely in the last 5 years with the introduction of immune checkpoint inhibitors, which has now superseded chemotherapy in the second-line space. There is a discussion going on about their role in the front-line space. Both atezolizumab and pembrolizumab have a front-line label. That started in all comers, and now it's switched to only biomarker-positive patients. That's a big change, and it suggests both the EMA and FDA have seen information which suggests that these single-agent therapies in cisplatin-ineligible patients are not working in biomarker-negative patients. And while we haven't seen the data, one would assume they wouldn't have changed the labels without very good reason. So I am not now treating patients who are biomarker negative with immune checkpoint inhibitors. We know single-agent immune checkpoint inhibitors only have modest activity in unselected patients in this space, with response rates in the region of 25%, where chemotherapy can sometimes go up to 50 or 60%. And so we really are trying to identify that group of patients that respond, that have long-term durable remissions, and we're going to have to use biomarkers in the frontline space. We know that the PD-L1 biomarker has now been recommended to be used by the EMA and FDA, which must, I guess, mean it works, but we do need to see that data. In the first randomized trial, Danube, randomized phase 3 study, comparing chemotherapy with two immune therapies, monotherapy and immune combination, should read out in the not too distant future, and that will be the first trial to read out, and that will define this space, and that information is extremely important. How do we move this forward? Well, we've talked about immune combinations, durvalumab and tremelimumab. At this meeting we saw some data on ipilimumab and nivolumab. It looks like the higher dose of ipilimumab may be more active than the lower dose, with response rates up above 50% for immune therapy for the first time. That looks really competitive. So that combination looks attractive, and that combination is in randomized phase 3. And even if durvalumab and tremelimumab fails, it doesn't necessarily mean that a subsequent therapy using drugs at different doses may be successful. So that's with the excitement around the immune combinations. The second piece of this jigsaw is around the chemotherapy combinations. Can we reproduce the lung cancer data in urothelial cancer, where you give chemo and immune therapy together and you get astonishingly good results? We're going to test that theory, 2 studies, Vigor 130, Keynote 361. Those 2 studies will really test this hypothesis, 3 arms of immune therapy, chemo combos, or chemo alone. And that will test that second question. And then the third question is around targeted therapies. We know that targeted therapies such as FGF inhibition appears to have activity in this space. And the question is whether PARP or FGF plus immune checkpoint inhibitors can actually change the landscape. And so those for me are the 3 key questions. Combination therapy, biomarkers we've talked about already. There's a second generation of biomarkers that we think are interesting. Tumor mutational burden, T effector signatures, TGF-beta. These triad of second generation of biomarkers may be able to build on the PD-L1 and select patients more carefully. And the last piece is around whether we just keep moving the drugs earlier in the disease setting. And it looks like the disease, and we saw actually yesterday, activity in non-muscle invasive disease with pembrolizumab for the first time, impressive activity. And so those 3 pieces, early in the disease, better biomarkers, better combinations, is where bladder cancer is likely to end up.